This is going to be a conversation. None of us have PowerPoints. The purpose of this panel was to really share community perspectives. And we were really cognizant as the last panel that we were going to come at the end of a really rich day and a half of discussion. So we met over lunch and talked more about what we were hearing and what we thought could be additive at this point. So hopefully we can capture some of that. So I'm just going to mention everyone who's on this panel, most of whom I think everyone knows, and then start throwing out questions that everyone will share their thoughts on. We'll do that for a little bit on a few questions and then go to interactive stuff. So going down the list, from the Human Rights Campaign, we have Shane Snowden, who's the director of the Health and Aging program there. From the National Gay and actually, this is not written in the order that we're sitting, so I'm going to read it on here. From the National Gay and Lesbian Task Force, we have Stacey Long, who's the director of Public Policy and Government Affairs. From the Black AIDS Institute, we have Phill Wilson, who's president and CEO. From CAP, Kellan Baker, who's associate director of LGBT Research and Communications Project. From the National Black Gay Men's Advocacy Coalition and FHI 360, Cornelious Baker, who's senior advisor and technical advisor, respectively. I think I got that right. And then from Equality Florida, we have Nadine Smith, who's CEO and executive director there. So lots of different perspectives. We actually have the two main organizations representing different parts of the LGBT community. So I think we have, having heard all the conversations, the challenges, the barriers, the opportunities, I guess the first question I want to ask, and I hope we also get at this, because a lot of us here are working at the intersection of community and policy, so trying to take policy change that's happening at the national and state and local levels and really translate that for communities we work with. So hopefully we'll get at those issues too. But the first general question is to ask everyone if they could speak to what are they hearing in the communities that they work with, try to reach, about PrEP, about TASP, about treatment for HIV, or just maybe even about HIV. And we talked about this at lunch, so there's a lot of varied responses to this, and I think illustrate how far we have come, but also where we need to go. So there's no really great order for this, so I'm going to start with Shane at that side.
Can you all? Oh, yes, I think you can hear me. First of all, my apologies to the panel and you all, because I have to leave at 4:20 sharp with the pike closing, blah, blah, blah. So I would love to be here for the interaction, but hopefully, Shane, HRC, you'll get to me by Google. I mentioned earlier that HRC is really getting on board with HIV. It's overdue, long overdue, but HRC has created a health and aging program. I'm its director after 14 years doing LGBT health work. I know a lot of you from that. We are really trying to put the pedal to the metal respectfully and in a value-added, hopefully not reinventing the wheel kind of way on HIV/AIDS, and that very much includes PrEP. As I mentioned earlier, we highlighted PrEP in 5 blog posts a couple of weeks ago. We also put it in our Equality magazine for our 1.5 million members and supporters. So there are 2 key constituencies of HRC that I would mention in connection with your question, Jen. One, as you may have heard, the largest constituency within HRC is middle-class gay men. Such a shock. So let me say a little bit about what I've heard from that constituency, both in HRC terms and in my context over the years. And what I've heard from them, I think, is very much what has already been set up here, that there is a lot of concern on first learning about PrEP, about I don't want to be medicated. One of the reasons I'm careful, and one of the reasons I, try to avoid becoming positive, is I don't want to be medicated, and I don't like the idea of a medicated, more medicated gay and bi men wandering the world. Obviously, they're concerned about long-term effects. They know, they aren't that well researched, although it's been a treatment for POS people for a long time. They're concerned about drug resistance in addition to, whatever kidney bone effects might happen over the long term. They're concerned in the short term about side effects. They're concerned about the efficacy of the med. If it has been shown not to be efficacious, is that really about adherence? Or is there something about that med that's not quite, doesn't quite work in this context? They're concerned about the cost to them, really concerned about that. They're not familiar with the, patient assistance programs. They're not familiar with other ways of driving the cost down. And as already has been said, they're concerned about seeing themselves and having others see them as Truvada sluts, I'll say. rather than whore, trying to reclaim a word there. However, I do think, and I think the analogy to contraception goes so far and definitely not further. Gina and I were talking about that earlier as women of the generation who were the big adopters of contraception. The analogy doesn't go a long ways, but I think the analogy to contraception does tell us that you can take a group of people who don't want to be medicated, they're concerned about long-term effects, they're concerned about side effects, they're concerned about efficacy and cost, and being seen as sluts, and you can really bring them around. I mean, that's the story of contraception, that they can get comfortable with it. I mean, that much we can say. So also, the questions become more, I think, for them, how am I going to talk to my provider about this? And they're concerned on two levels. One is, I'm going to have to come out to my provider as gay and as sexually active, having anal sex with another man. And I'm probably going to have to educate my provider because you tell me this is brand new. And I actually am kind of optimistic about the scenario, and again, I take this from contraception. I'm pretty optimistic about a scenario where people go in and say, I'm really scared about what could happen if I have sex. I'm really scared of a hideous outcome, be it an unwanted pregnancy or seroconversion. Give me something. And providers, they don't necessarily even need to talk about sex, let's face it, and they haven't with women. It's like, oh yeah, tell me no more. Here's your script. That's where we're at. I mean, as women, we know this. You don't have to talk about sex. So I think that the tricky part is not the conversation about sex, because they'll avoid it, and I think that's okay, but that you are coming out. You are coming out as a gay, bi, man, or a trans woman. And I think that we do need, and this is a larger question in LGBT healthcare, we do need to give support and scripts and scenarios about coming out to your provider. How do you do that? How do you make the space, both of you take a deep breath and say, I'm scared to tell you this, but I'm going to tell you. And especially if I don't look it, I don't seem it. I may have told you something very different about myself, but I'm a gay man concerned about, or a bi man or trans woman concerned about anal sex. I want this med. I think we could do a lot more scripting around that. I also think, and we touched on this earlier, and I think Neil and Jim mentioned some great researchers, I think we're going to have to rely on gay, bi, men, and trans women to educate providers. And there's a history of women doing this. There's a history that's happening in the context of ACT UP and HIV/AIDS early work. I think, though, we need, again, just as we need to put together resources for coming out to your provider, if not talking about the details of sex, I think we need to have a little package. Oh, look, here's a journal article from the Annals of Internal Med. Oh, look, here are the Gilead REMS. You don't have to know what REMS stands for, but the provider goes, oh, REMS, really? Also, we need to have for the patients themselves things like prepfax.org. I mean, it isn't well known. We need to have Sean's Fenway brochure out there. We need to have really accessible ways for patients to find out. And I know that HRC can really play a role in terms of the scripting and the resources that you can just plunk down in front of your provider. I mean, we plunked down our bodies ourselves and said, turn to page 81. Read it. Get it. Yeah, we're going to talk about down there for a second. So that's, I think, we've already said a lot about gay, bi, men. So I'd reiterate that and just pledge HRC to do something. The other constituency that I think of in terms of your question, Jen, and I have a question about how much we need to engage with these folks. One thing I've been thinking about is, could PrEP be our own project for a while? How much do we need to worry about the perceptions of people outside gay, bi, men, and trans women? And I think at the least we probably want to have done some thinking and talking about how this is going to be discussed with, first of all, lesbian and bi women. The next big constituency of HRC is lesbian and bi women. What's the next one? Huge numbers of straight ally women are now engaged with HRC. Marriage equality, bringing them on in. So I think we want to think about, with lesbian and bi women, straight ally women, and the general public, how are we going to talk about this? Because it's interesting. Here's where the analogy to contraception breaks down. Contraception has really been viewed overwhelmingly as you take that to prevent a really bad thing from happening. We love kids, but not when they're unwanted. You take that to prevent a bad life event from occurring. We're down with that. Now, we know that contraception massively increased straight women's sexual activity. Yes, yes, yes. The source of the sexual revolution. But it was not discussed in terms openly of, oh, this is going to make possible a whole lot more sex with a clear and mind at ease. So I think the problem potentially is, of course, with lesbian bi women and the general public is, oh, so this is so because you guys don't want to use condoms. Aha. And it comes with a big price tag, you guys not wanting to use condoms. You're telling me that, you know, as a member of a health plan, or you're telling me as a taxpayer, or both, I'm going to pay because, you know, these guys don't want to use condoms. And I think, unfortunately, to the extent that I'm hearing, I was just at a lesbian health conference last weekend in LA, you know, not Outer Mongolia, and this is what I was hearing. So guys are tired of using condoms. Well, they weren't making the, especially because they were lesbians, is, you know, lesbians can easily say, condoms, schmondoms, no problem. We haven't, you know, they haven't figured largely in our lives. But I think we need to make sure that this is not seen by them as, oh, so you guys don't feel like using condoms and we had this huge project and a big price tag. I think, and I don't, you know, I think we're just at the beginning of the conversation about the general public, but I would toss out a couple of ideas around this, the ways that I've talked to the general public and lesbian and bi women. One is, actually, it's kind of a version of, you should pardon the phrase from HRC, marriage equality. I think we can use a leaf from the marriage equality book and say there's no reason why gay and bi men and trans women should not be equal in their sex lives, should not be able to experience sex without fear. And leaving aside the question of who's using or not using condoms and why, equality, sex without fear, without the cloud of fear hanging over, has been very effective. The other thing I think has been very effective is, bottom line, let's leave aside the question of condoms and cost. I don't think that's necessarily an argument we can win with some people. But bottom line, this is about this person will seroconvert. They will get HIV/AIDS, it seems very likely, or they wouldn't be taking PrEP unless they get PrEP. You don't want them to convert, do you? Do you really? Don't, you know, open your heart and open your mind. So those are some beginning thoughts I have about that. The final constituency with which HRC engages all the time, because of course we're a punching bag, not just within the LGBT community, but also, you know, of the right wing, is that if the right wing finds out about this in a big way, if this hits Fox News, I think we really want to be ready. We can see what they're doing with the California law, transgender people in bathrooms. They could do a lot about the taxpayers paying how much so these guys can have anal sex, male anal sex without condoms. I think we really need to be ready for that. So those would be my HRC-based thoughts.
Thanks, and hopefully we can get into some discussion. I think you're raising some really good challenges to think about reaching community, because there's the community we're talking about that needs PrEP. Then there's a community that we need to, that can reach them. And then there's allies, right, who we at the very least want to be supportive or at least not harmful. So those are, I think, different constituencies. So I'm going to actually ask Stacey to go next to just tee off and go to the NGLTF. And I just want to preface it by saying that a year ago, a lot of the conversation around where NGLTF and HRC were around HIV was much further back. And I think there's been a lot that's happened in the last year, so we should acknowledge it, and I think we're hearing some more about that today.
Yeah, so, excuse me, thank you. I think that, you know, first off, I just want to acknowledge that prior to today, we had not been having very much of a conversation about PrEP. And I think that aside from the fact that I feel like my head is going to explode because it has absorbed so much data, but we have some real work to do. I think that the task force has very, very deep and strong leadership roots historically on the HIV/AIDS movement, having hired the first attorney to work on this issue on the Hill. And I think over the years we have had a presence, but it has somewhat dissipated. And under my leadership in the policy shop, we've been focused on making sure that appropriations are there and supporting that. We've also weighed in on the issue of HIV criminalization, and we've also focused on just general wellness and eliminating health disparities. But this is a newer issue for us, so I'll acknowledge that and just say that it presents for us a tremendous opportunity going forward, because our base of folks who are interested in what the task force is disseminating in terms of a worldview is, how can I continue to live my life? How can I enjoy my erotica? How can my erotic self via erotica? We're having a conference, Creating Change, which is providing a space for close to 4,000 individuals from across the world to be able to sit down and trade notes, build community, learn skills. And this year's conference, or 2014, the conference is in February, we'll have a plenary discussion, and the plenary easily has 1,000 people in the room, 1,000 individuals who can have leave-behinds in their hands, the mini script that Shane described. Whatever we want to disseminate to people, we can be sending them mobile texts if there's an action that needs to happen that day. But it's a real tremendous opportunity for there to be visibility and awareness, education, and real action, which is what we're known for. So leave it to us, and we'll be sort of figuring out how to make action on PrEP hot and sexy. So, and we talked about some of that earlier, just sort of figuring out how to put the sexy back in our movement with respect to PrEP. So that's really exciting. I think that we're going to be having some more conversation about what it means for our movement, but just quickly I'll say that we have been fortunate to work alongside leaders within the reproductive justice movement. I was thinking reproductive rights and reproductive health. They're all three separate movements under one big umbrella, and you thought you were complicated. And immigrant rights movement. And so we've been talking about issues of equality and justice for people who are at varying levels of acceptance within the community, within the world, people who don't have proper documents to be able to matriculate and move freely through the country. We've also talked about racial profiling. So I think it'll be really interesting for the task force to push this issue through our unique intersectional lens. And I can assure you that we'll be thinking very deeply about what this means for trans women, what this means for bisexuals. We haven't talked very much about bisexual people, but bisexual women who are queer identified just certainly have a particular risk if they're engaging in the behavior that that exposes them. And we'll also be definitely looking forward to continuing to talk about ways in which the individuals who don't have personal power or personal agency can really deliver to themselves and to their peers a sense of what is possible for them through a conversation like the one we've just described with a provider. So if I'm not comfortable even talking about this stomach ache, or I have historically not been treated well by the medical establishment, I'd like to know how I could feel empowered to actually talk about something as deeply personal as my sexual practices, my sexual behavior. So I will leave it at that and just move on to the next question.
Actually, I'm going to move on to the next person, and that's going to be Kellan, who I'm going to ask you later more about the ACA, but just in general, the same question about, because I know you've been trying to connect focusing on HIV with LGBT health more broadly, and just want to get your sense of how that is going, or is HIV on the radar of the larger LGBT health discussion, let alone PrEP? So.
Sure, and I can hear the occasional roar or announcement from the park back there, so, I'm well aware that, don't run us over in your rush to get out of town before this starts. With regard to where I am in the mix around LGBT health and HIV and health reform, a lot of the work that I do at the Center for American Progress is focused on the implementation of the Affordable Care Act in a way that makes sense for LGBT people and their families. So I talk with a variety of LGBT health advocates, consumer health advocates, HIV groups, the federal government, various state governments, and really what I've been hearing around PrEP, around TASP, around really even HIV and some of the mix around the health reform question is a whole lot of nothing. And I think it goes back to a couple of issues that we've talked quite a lot about today already. The sort of historic divergence or historical divergence between LGBT health and HIV, which is only now starting to come back together thanks to the efforts of so many folks here in this room. Also looking at the difficulty of the conversation about prevention, period. Because we know one of the reasons that healthcare costs so much in this country is because we don't pay enough attention to prevention, right? So the Affordable Care Act is an attempt to reverse that, to actually focus on getting folks services, getting them care before they become sick, before they need it. But that's still, I think, something that's very much an uphill battle when we're thinking about how we as a society are valuing the different parts of our health system and figuring out how they can serve people who need various kinds of services. And so I think the last thing that I will say around this sort of the question of where in health reform is LGBT health, where in health reform is HIV, I think we in this room have the privilege and the opportunity to talk about these issues in a way that really doesn't rise to the surface for a lot of people doing health reform work on the one hand, and for folks doing LGBT equality work on the other. And Shane and Stacey have alluded to this a little bit, but it's very true from the perspective of the work that I do that health is a really hard sell. Prevention is a really hard sell with the health, some of the organizations working on health, but health is a really hard sell when it comes to talking with LGBT equality organizations who have so many other things on their plates, and where we haven't really done, I think, a lot of the work that we could be doing or that we will need to do to develop a common language around why equality has a health component, why access to PrEP or access to care, coverage, services is something that is actually deeply embedded in the structure of the LGBT equality movement, and how we can be using opportunities like the Affordable Care Act, as imperfect as it is, to actually jumpstart some of those conversations about prevention, jumpstart some of those conversations about where health needs to be on, sort of our national radar, and where health, whether that's LGBT health, and I would include HIV and LGBT health under the same umbrella, figuring out what kind of common language we need to have in order to be using the language of equality and social justice and social change to talk about why getting access to services such as PrEP or any of the other benefits afforded under the Affordable Care Act is so important for LGBT people.
And I realize we're actually getting through our time too fast. So Cornelious, I'm going to turn to you to talk about, I know you've been doing a lot of work specifically focused on the target population, the folks who we really think should be considering PrEP. And so what are you hearing there?
So I'll talk about two elements. First, our work at FHI 360, where we implement the beta generation bridge project, which we also work. Oh, sorry, I thought this was on. Which we also work with Black AIDS Institute and San Francisco AIDS Foundation. You've heard their work earlier in AVAC and others on an MBGMAC. And we've been engaged in a round of focus groups and interviews with providers over the last few months, trying to develop new products to educate both the general public, but also specifically providers and community leaders under very much the theory of the fusion of innovation theory, to look at how are we getting this in the hands of people like you and innovators and community leaders, so that it gets diffused more into the communities. Because what we've learned over the past few years is that still most of the key populations that are affected by HIV in the United States have two trusted sources of information, well, three, the CDC being the highest. Almost across the board, people want to hear from the CDC. And then secondly, their healthcare providers. And lastly, HIV/AIDS organizations who they consider expert, at least in the question of vaccine, PrEP, treatment as prevention, microbicides, research. Those are the areas that we've been asking them about, both to further the research, but also to prepare for readiness in the introduction of products. And so I guess a couple of things that I would highlight. First, that generally across the board, with some increased knowledge among gay white men groups that we've interviewed, there's low literacy. And I would include the providers in that. We've been interviewing a wide range of healthcare providers, and generally the level of real knowledge about the research that's taken place or about the interventions themselves is fairly low. And so we've tested our materials, of course, to see if that improves it. And it has some benefit, but there's a lot of training and new technologies for training that's needed. The second thing is that in the various communities, what we're hearing are overall a general concern about safety, that everyone's concerned not only about the safety of the research that's being conducted, but the safety of the products. And they want to know more about what the risks are. There are some populations where there's some interesting divergence of opinion. Particularly highlighting transgender. We just did a group in Atlanta of transgender people, mostly male to female, but it was diverse and mostly African American. And it was interesting, the questions about PrEP potentially leading to more sexuality, more sex, and more risk for the population. But the other big issue that came up among transgender people is that they would not have it, that they never get anything, that they're always last on the list. And so there was a great deal of circumspection about all of these technologies and whether they would ever be for transgender people. We did a group of white gay men in Washington 2 weeks ago, and it was it was very fascinating that it was the only group where there were two people, one in particular, who talked about how the product was Truvada, how it was made by Gilead, how it was approved by the FDA. But what I found very interesting was the same person said, but I don't see any mention about it being used for prevention on any of the ads. I mean, there was that level of awareness that this person had, and I think we have to think about that. If there's this product, people know about it, and then we're not being clear, again, with the messaging about what is it for. And that's being noticed, and so we thought that was interesting. I would point out that the materials and the education that we were testing simply did not resonate with Black gay men, and we've got to think about our technologies around that education, and we also have to think about the framework of that education. Lastly, across the board, biomedical is a word that we're simply throwing out. People rejected it across the board. It sounded scary. It was menacing. They didn't like what it might imply for their bodies. They did like HIV prevention research. We tried out several different formats of how to educate about these technologies. And people ultimately said to us, it's all prevention. And so we have to think, and I think this goes in some parts to Jim's part, the whole spectrum is prevention. And how do we change the paradigm that is not condoms versus, or this versus, but this is all prevention. And how do you pick the strategies that are most protective for you? Now this work, and then I want to talk about MBGMAC and very quickly. And one, I want to acknowledge Douglas Brooks, who's in the room, because even before the approval by FDA, Douglas led a group within MBGMAC, which is the PrEP working group, to really sort out what Black gay men were thinking about PrEP and Black gay leaders, and developed a paper. Go to the MBGMAC website, it's on there. I'm not going to talk too much about it now. But we've been following that up along with Advocacy for the HPTN 073 study and others to look at how do we actually find out how PrEP is going to work for Black gay men. And we're glad that that study is getting underway with Sheldon and others. But we are also doing a series of discussions around the country. We started them last night in Baltimore, and in partnership with Gilead. We're not receiving any grant support for it. They're paying for the meals, and we're recruiting the people to come to the sessions. And we have ex-physician Phill Hodge, who's talking about where we are in treatment, and then we're holding a policy discussion. And so last night, and Ernest Hopkins and Vinton Jones went last night. I was here, of course, with you. And so they texted me this morning and emailed me last night and this morning about what the conversation was. And there was so much discussion about housing and about homelessness and about people not being able to focus on any of this or on HIV because they're hungry, and how in a lot of folks, they really don't have a choice around prevention because they have to prostitute to get a place to sleep or get a place to eat. And we do have to think about this in the context that the population that we're most trying to reach now also exists in an environment of sometimes 30 to 50% unemployment, a severe lack of housing opportunities, and needs like hunger. And, you know, we may not be like contraception totally. We actually might be more like the education system. It's hard to educate young people when they come to school hungry or they're living in substandard housing. And our programs may need to go through the revamp that education has had to go through to figure out how do we connect better with this population that needs to be educated, and we can't afford to have drop out. They're dropping out of our healthcare system. And the ACA won't necessarily fix that, especially for young black males. And I think we just have to be really conscious of that so that we don't go into this with magical thinking. Now, we can make tremendous improvements, but this is going to be our biggest challenge, how to make these products work for black men in systems that aren't well designed for them. And so that's what we're hearing.
Thanks. I was going to say, wow, you were in Baltimore last night and here. That's pretty amazing. But of course. So I want to pick up on something you said about providers, because I know that Phill recently conducted some research with HIV providers on some of these issues and has some pretty alarming results, I guess. So would you share those?
Well, to quickly answer the question up front, that we're not hearing a lot about PrEP. You know, I mean, some of the concerns that people express, I aspire to get to that place, you know, to have a conversation where we're actually having debates in the communities that we're addressing. As Jen mentioned, not only about PrEP, but about biomedical interventions or, quite frankly, AIDS treatment, those conversations in many of the places that we work, those conversations really are not happening in a robust way. As Jim mentioned, we did the Black AIDS Institute did the first ever national KAB of the AIDS workforce. It was a large study that we did this summer, nearly 2,200 respondents. These are all people who work in or volunteer in either AIDS service organizations, community-based organizations whose primary work is HIV, or health departments. That's the audience. Across the country, with a heavy emphasis in 12 cities. Those 12 cities were Philadelphia, Jackson, Mississippi, Houston, Atlanta, Chicago, Los Angeles, Miami, Fort Lauderdale, New Orleans, Baton Rouge, San Francisco, Oakland, more than 12, like Baltimore, New York, and Detroit. But it was a national survey. We did it in partnership with the CDC and Johns Hopkins. And these are not just black respondents. This is without regard to race, sexual orientation, gender, amount of time in the field, or all across the country. So to begin with, on the front, one of the questions was, we wanted to find out what people knew about HIV and AIDS treatment and science, and what they believed about the efficacy of the new technologies. So let's start with the new technologies. One of the questions was, how familiar are you with PrEP? Only 37% of our respondents. Again, these are people in the field. Okay, these are the people whose job it is to get people on PrEP. Only 37% were familiar with PrEP. Okay, topical microbicides, only 26% were familiar. On vaccines, only 27%. Treatment as prevention, only 44%. Then one of the other questions we wanted to get at is how much confidence did they have in the new technologies? 35% of our respondents, again, these are people who are in the field, did not believe that PrEP was effective. 40% did not believe that topical microbicides would be effective. 26% did not believe that vaccines would be effective. 24% did not believe that treatment as prevention would be effective. On the upside, 84% did believe that suppressing viral load would help in reducing risk of transmission. 34% did not believe that PrEP or treatment as prevention would reduce infections. 42% did not believe that PrEP could impede existing HIV prevention, could help existing HIV prevention efforts. So that's basically, we have a workforce that is not familiar with what we're talking about, and to the degree that they are familiar, they don't believe it. It gets even worse, actually. because that's the belief part of it. The knowledge part of it, and we're trying to assess three things actually: treatment basic science and terminology, treatment and clinical science. And what we found is that people did the best in basic science and terminology. Basically, if it was an academic test, they scored like 76% in basic terminology. Basically, they were getting a C. Gina and I talk about our kids all the time. And when you brought home a low C, at least in my house, that was a problem. Okay, but it gets even worse. When we tested them on their competency on treatment across the AIDS workforce, people are scoring 55%. And when we tested them for clinical or biomedical interventions, 45%. And so we got back this top line. We're preparing a manuscript for publication. When we got back this information, like one of the first questions, this is actually the first thing I saw when I came back from sabbatical, by the way. This is the first session that I did. Exactly. I kind of like, it's a wonder we're succeeding at all on anything. So we have a huge problem, Houston, with both our knowledge for the folks that are in this field. Again, these are people who get a paycheck, every week or every month or however you do it. These are also people who work in health departments. People who worked in health departments did slightly better on average than people who worked at community organizations, but not a whole lot. People who worked in health departments scored like a 66%. Compared to people who worked in community-based organizations at about a 62% on average. That's across all three categories, subject matters. So we have a major problem with what our communities know and what they believe in. On the issue around, I think, community involvement in the LGBT community, I think that I'm really, really excited about the larger traditional LGBT organizations kind of getting re-engaged. I think that that's important. I think, quite frankly, over the last 10 years, our community as a whole has been absent. That we did a very successful job of there being an AIDS movement, of which there are people who happen to be LGBT who are part of that movement, and there's an LGBT movement, of which presumably there are people who are living with HIV that are in that movement. But they have been distinct and separate movements, for a long time. And so a lot of our work really has to be about re-engaging, that community, which continues to be the most impacted community around HIV. And particularly when we talk about, young black MSMs, who are being devastated. Black MSMs in general are being devastated by the disease, but particularly young black MSMs are being devastated by the disease. And if we actually believe our hype, if we believe our press, our message that we either believe in or we've co-opted is about equality. And yet there's a total disconnect about equality when it talks about internal to our community. And that speaks specifically around how stigmatizing our language has become in the world of HIV. Now, the fact that the Truvada whores or Truvada sluts, that's a part of our vernacular, it's like really scary and shocking to me. And it speaks, quite frankly, to how sex negative we've become. That the issue around the things around Truvada whore and what have you, that's because that we've gotten to the point where somehow there's something fundamentally wrong with having sex, and that's a conversation that we need to come back to because that's a problem for us. Inside the community, we talk a lot about homophobia, and how other folks treat us, and that's an important topic. But we talk almost nothing about what we're doing internally, around stigmatizing HIV. That you go on to any of the sex sites, or connecting sites, and there's all this stigmatizing language, about clean and dirty and what have you, or rejecting people who are living with HIV. Even the notion, I have, I'm on Facebook, I'm on Twitter, I am on Adam for Adam, I'm on whatever, I'm on all of those different social media whore. Right. Yes. So I have profiles in all those sites, and I have people. Two funny things, and I'll shut up. One is that someone sent me a message saying you should take down that you should take down his picture. This is a terrible thing that you're doing. He would never be on this site. Now, so it's like they assumed that it wasn't me. Like I have my picture and everything. I have my picture. I have where I live and what have you. Who else would it be? And so I thought maybe I should look at my profile. Maybe I'm saying something that I don't think that I'm saying. And there's nothing like provocative. I don't know why this person was so upset. And then I had someone who came to me and said, Phill, you really should not have profiles on those sites. And I'm like, excuse me, I'm an openly gay man, and it's a mistake for people to think that someone in my position, is not involved in those things. I mean, that's a mistake, and anyway, and that just speaks to kind of the negative, our attitude. There's something fundamentally wrong with the whole notion, and that we should not be having battle. I mean, the argument that we can't promote PrEP because it means that gay men are going to be having sex. I don't think that's a winning argument within the population we want to reach. Now, we need to figure out a way that there's a connection between PrEP and having sex, and that's a good thing, because bad things happen when you suppress your sexuality. We know that. But I do want to say that, and then I will definitely shut up, that I don't want to give up on condoms. Sorry, Jim. I don't want to paint the picture of condoms or PrEP. I think that they're 70% effective in the condoms. I want to keep that 70%. I don't want to lose. I don't want to see anything. No, so I'm done. Sorry.
Thanks.
I get riled up sometimes.
It's the last time of the day, so we just to pick up on something Phill said, we at Kaiser have done focus groups with gay men and found definite internalized stigma and homophobia around HIV status as well. So that is something we've done. We've just launched a new campaign, a media campaign to reach gay men to talk more about HIV and sort of bring HIV back into conversation in a destigmatized way. So I think this is a good segue to Nadine, who is sort of at the nexus of thinking about equality, where we are with the marriage equality and larger LGBT rights movement and HIV in your community especially.
Well, I thought Phill had gotten over that note I sent him. It's embarrassing. It's always awkward in these conferences because whenever Florida gets brought up, it's rarely pleasant. But I do think, to answer the very specific question, what are we hearing about PrEP? Almost nothing. And in truth, somebody who's a very vocal AIDS activist in Florida, when I was talking to him about the conference, he said, I should just come out of the closet to you about being anti-PrEP. I think it's going to lead to people abandoning condoms. I think it's going to increase risky behavior. I think it is, just sort of a recipe for disaster. And so right after somebody said Grandma Barebacked, who put that in their presentation the first night, I thought, I do think there's this message here that we ought to get back to, a sex-positive message. And I texted him back and I said, I'm kind of pro-PrEP. And then I listened to presentations earlier today and I thought, okay, I'm ambivalent again, But I do think it kind of comes down to what you raised earlier, these twin messages of it's the alternative for people who just won't use condoms, and we've got to find, a rational way to respond. But all of the conversations, top HIV doctors in Florida saying it's an extra layer of protection. Well, that's not, again, it's not reaching the audience that we've spent an awful lot of time talking about. What we do here on the occasions that this topic does come up, it tracks what Shane talked about among sort of people with some wealth, some privilege, some comfort. Why would I want to take a daily drug when condoms are pretty much free, and for the episodic sexual encounter, why would I, who wants to take a pill every day? Suspicion about the side effects. Has there really been enough study that no one will be that consistent, and what will the repercussions of that be? And also sort of questions about, for example, Jacksonville has had more young people more HIV infections than Orlando or Miami among young people. And there's a great organization there called Jasmine that does very heroic work. And PrEP is absolutely not a conversation that's happening among that population, that young population. Even in treatment as prevention conversations, it's not there. And for them, it's all about linkage to the entire spectrum of healthcare and safety and harm reduction. And so the idea that the overriding message would be about a blue pill as opposed to more immediate needs, it just isn't part of that dialogue. So when Shane or Stacey start talking about here's part of the recommitment, I've been part of those conversations along with Phill about how do AIDS and HIV organizations and LGBT advocacy groups sort of come back together and figure out ways to work together. I think it has been, in my experience, not a someone left the other, but a divorce, growing apart over time. And so the coming back together, here's what I will say. I don't leave here thinking Equality Florida now needs to launch a big PrEP push, and I just need to get some ads, and we'll put our logo on one side, and we'll make sure that we e-blast this out everywhere, and we'll have a couple of town halls. I don't leave with the confidence that that's where people are. I think I don't. And I think that's part of how the growing apart happened. I mean, I remember in the early days, we'd have, the state AIDS advocacy organization would say, hey, this is the legislation we want to work on. We'd put it in our portfolio. Then there came times when advocates would say, listen, our funding is going to be threatened if we are very visible, but we sure hope you guys will fight on this. And then there came the time when they would say, listen, would you guys stop fighting so hard on that bad thing because it's jeopardizing these other things? And over time, there just stopped being that level of communication and coordination. And so I remember when the PEP, when PEP conversations came up, and the same kind of dynamic of some people saying this is absolutely, we've got to get this in everybody's hands, and others saying this is going to encourage irresponsible behavior, and we can't be reckless. So I think LGBT advocacy organizations in the push and pull of some of our friends are advocating this, some are advocating the exact opposite, have kind of said, well, where we have consensus, we'll dive in. But where there isn't, there's a lot of sifting through to figure out where we should stand. And so I even now, I don't leave here thinking, well, Equality Florida is going to have a PrEP division now. I leave here thinking I need more clarity on what the message is, because I do hear two different messages. This is for a population that doesn't want to use condoms for all of the good sex-positive, healthy reasons that grandma didn't, want them either. But the other message is this is this is equal to, it is the equivalent of being responsible in the same way using a condom is being responsible. So anyway, I'm glad that this conversation is happening, and but I don't leave here with a sort of clarity of the next step.
Yeah, I mean, I think while we're waiting for a question, I mean, and I think Nadine's point is apt, as well as what we heard earlier from Shane, but I guess as we're thinking about a paradigm shift, I guess the question, I mean, I think your question is born out of the science, will it work? And I think that that's an important question, but I don't know if we're still going to have Kellan talk more about the ACA. But I guess from the equality perspective and the sort of civil rights, social justice, and health rights perspective, I guess the question is, if we have an approved treatment for that can combat a condition that affects a significant component of our population, and it is the leading cause of premature death for gay men, why wouldn't our advocacy premised on the fact that people should have access? And why wouldn't we premise our advocacy on that individual choice? I may not like abortion, But I don't need to debate the morality of abortion to know whether a woman should have access to it. And so, and I guess I'm just confused about, for gay people, why we would not just predicate that on our having the choices that should be available to us.
Well, yeah, just to respond to that, I'm actually not even talking about the choice. I mean, I feel like much of the conversation here has been, how do we market this? Not that people are, I mean, I can tell you more people I know who've taken it and stopped taking it. You know, so, so I don't think that's even the conversation. If it is, the access and choice part, I don't know that anybody disagrees on access and choice. But I do think that there's a conversation about, are we taking a posture that this is what we should be pushing our community to adopt as a, as a standard?
That was very clarifying.
So one thing I want to say to that, and then we actually have a slight change in what we're going to do, is I wonder if the question for Equality Florida is not, do you have a PrEP division, but how do you further the discussion about HIV within the larger equality movement in the circles that you are interacting in, of which that will create a more supportive environment for those who need access to PrEP and other things to live. So I think, I wonder if that's the question, rather than now there's a PrEP division in every state equality organization or in every LGBT organization, because I think there's still a lot of unknowns in the larger HIV community about how to market and talk about this.
And I think on that, I think that the part of the problem that we're having, I mean, most of our work is centered around working with traditional black organizations, the NAACP and the Urban League and all of those groups. And one of the things they say to me is that, Phill, why is it that I have to have 5 or 6 different presentations to cover AIDS? I have to have a presentation that's on PrEP because they only talk about PrEP or vaccines, and then I have to have a prevention, and then or a treatment or an advocacy. I mean, when the cancer people come to me, Phill, they talk about cancer, and I'm done. I have to deal with cancer and diabetes and obesity and AIDS. So you AIDS folks, I need you to come to me and talk to me about AIDS, not all the minutia. And so I think part of the conversation is going upstream a bit. And so what I would say to you, Nadine, is that no, I don't necessarily need Equality Florida to talk about PrEP per se, but I do need HIV and AIDS to be a part of your portfolio, because you're supposed to be an advocate for LGBT people. I'm a gay man. AIDS is important to me. My life is dependent on it. And if you're not dealing with it, if your folks not dealing with it, that means that I don't matter. Now, and that means that the 50% of black men who may already be HIV positive, they don't matter. And so that's the conversations we need to start having in our communities. And we have those conversations, all these details, we get to that, but we've abandoned the conversation altogether. So that's what would be my response to that challenge.
And so I'll add this. In the places where there's clarity, seriously, for example, sex education in schools or needle exchange, or where there's a clear policy, then it's easy. We go lobby the governor, we go work with legislators. These kinds of questions become, I'm not sure how to sink my advocacy teeth into the conversation we're having here about PrEP.
Okay, so we have a couple requests for a really quick comment. Kellan, I know you can be quick on ACA things. And I was going to ask you to speak specifically on non-discrimination, because I think that's a real way in which we can bring these conversations together. And then maybe we have time for 2 questions.
Thank you. Yeah, and I just want to say, I think the point about the minutiae question is something that's coming up quite a lot, sort of both when you're looking at the dynamics of what's happening with ACA implementation, whether on the national level or on the state and local levels, because when we're trying to figure out where does HIV fit in all of the work that's happening, there are so many pieces where it matters, that trying to distill out and say this is the place where we're going to talk about HIV, this is where we're going to dig down into TASP or PrEP or what have you, is not something that's capturing the imagination of the groups that are really trying to get back to one really simple message, which is health matters. Because right now there are so many ways in which health doesn't matter in our country and in the work that so many of us are participating in, just because we've been subjected to so many pressures, so many things on all of our plates. And getting back to the question of Why do we have health reform? It's not because we like to play with policy and we like all of the crazy details, although I do. Don't judge me for that. I see you judging. It's because health matters. And so I think that that's, in terms of looking at how we're having these discussions from the perspective of addressing LGBT community concerns in the implementation of the ACA, to Jen's question, one of the ways that we're trying to get back to that simplicity of message is to drill down into one of those sort of core areas that LGBT community members have dealt with for so long and so many other communities have also grappled with for so many years, which is non-discrimination. If you look at implementing the coverage expansion, you can get into all kinds of discussions about network adequacy and essential community providers and drug formularies and benefit substitution, and oh my God. When it comes to figuring out how to talk to the community members that we're working with and to the other organizations that are in different fields but are all working on that question of health matters, non-discrimination is one of actually the biggest places where the Affordable Care Act provides us with something to stand on and a little bit of that common language that I was talking about earlier when we're trying to figure out how are we messaging the importance of working on HIV, how are we messaging the importance of prevention, how are we actually drawing from all of the different movements that we've been, to Harvey's silo picture, drawing from all of the different movements that we've been siloed into and actually speaking, singing from the same score sheet. So just quickly with regard to the Affordable Care Act, I usually like to picture the non-discrimination protections of the Affordable Care Act as a triangle or a pyramid. At the bottom, the broadest one, Section 1557 of the Affordable Care Act, prohibits discrimination by any health entity, program, provider, facility, whoever that receives federal money. And that's pretty much everybody, right? So the protections of Section 1557 include all of the ones that exist in federal civil rights law already, such as race, color, national origin, disability, age. They also include sex. According to the Equal Employment Opportunity Commission and the Department of Health and Human Services, the sex protections of Section 1557 include gender identity and they include sex stereotyping. So that's huge. The department is right now writing regulations that would implement 1557. They're already taking cases, but everybody wants to make sure that the protections are codified in some regulations going forward. So that's what they're working on right now. I would really suggest that everybody pay attention to that process because the draft regulations are going to be coming out for public comment pretty soon, probably before the end of the year. The second layer up in the pyramid, so a little bit less broad, but still very significant, the non-discrimination protections that apply to plans offering the essential health benefits. An estimated 68 million people across the country will be purchasing plans that are based on the essential health benefit standard. According to federal law, any plan that offers the essential health benefits, which again, individual market, small group market, every plan sold to the marketplaces, 68 million people, cannot discriminate on bases including gender identity, sexual orientation, diagnosis, or health condition. So that, again, is huge. Nationwide, no matter where you are, whether you're in Kentucky, California, Maine, wherever. Next layer up, third layer, again, slightly smaller, the qualified health plans. The qualified health plans are the plans that are sold through the health insurance marketplaces in every state. According, again, to federal law, the marketplaces themselves, as well as the issuers of the plans, the qualified health plans sold through them, may not discriminate on the basis of, including others, sexual orientation, gender identity, or disability, which includes HIV. Again, every single state. And finally, going up to sort of the peak of the pyramid where a lot of the action for so many of us working in our states is concentrated at state law. We've actually seen some really impressive work happening around non-discrimination with regard to gender identity that's driven by the conversation around the ACA, but is implemented through state law. Most states have unfair trade practices laws and insurance. Most states have human rights protections that include some measure of protection for many of us in the LGBT communities. So for example, using the gender identity non-discrimination as an example, over the last year, 5 jurisdictions, 4 states plus the District of Columbia, have had their insurance commissioners issue bulletins saying that the existing non-discrimination laws in those states do not permit plans to use transgender exclusions. That's huge on a number of levels, but bringing it back to the conversation about HIV, one of the things that's been repeated frequently is that access to appropriate transition-related care helps with adherence, helps with outcomes for people living with HIV or people at high risk for HIV. So when we're looking at, the health reform landscape is so complicated and so fragmented. And I think one of the things that offers the best, from my perspective at least, so take my opinion for what you will, offers one of the best opportunities for actually driving the conversation forward, not just on HIV, not just on transition-related care, for example, for transgender people, on a wide range of issues affecting LGBT community members, is trying to, as Phill was saying, go upstream, find some of those simple messages. Health matters, prevention matters, non-discrimination is a real thing only in as much as we are involved in fighting for it.
We have time for one question if there's a question. And if there's not, oh, Chris, okay. And then we're going to hear from Ken just to wrap up. Chris Collins.
Great panel, and thank you everybody for what you're doing. I guess the one thing I would just say is let's put treatment access fully on the table too when we're talking about ARVs and community response, the needs for the LGBT community to get engaged, because we have a huge opportunity there in terms of saving people's lives and prevention, and huge disparities in our country and issues around people being concerned about it or not being informed about it or lacking access. So I just want to firmly put treatment on the table for all your activism that you're doing. Thank you.
Yeah, I'd like to thank Jen and the rest of the panel. It was very, very rich discussion. So the goal is to get you all out before the melee begins. I think it's been an incredibly rich conversation this last day and a half, and clearly we're not all in the same place, but part of the intention here was to really have a conversation and understand a little better some of the perceptions and issues that people are experiencing as we are in this new era of HIV treatment and prevention. I thought the exchange between Cornelious and Nadine sort of summarized some of the tensions we have for the different constituencies that we perceive we serve. And I would say that if there's the bumper sticker to go back to Florida, it would be take what Kellan said about health matters, and not so much promoting PrEP, but promoting health literacy and awareness. In other words, we have a community that I don't think we're serving well, or many communities, because so few people are aware of what the data are, and there are data. We can disagree about some interpretations, but we shouldn't disagree about facts. And over the last 3 or 4 years, there's a whole new set of facts that I think the community needs to be informed about, as at the very least. But where do we go from here? Well, we didn't expect we would have a consensus at the end of today. I really want to thank Sean Cahill for all his effort, and one of his next efforts is going to be trying to assimilate some of the discussion today. We're going to try to generate a white paper, which we will share with you. If the white paper makes sense, we'll try to see if it can be disseminated more widely in a journal. We also know that we had hoped, we had this sort of naive hope that all of our wonderful speakers would be submitting their slides well enough in advance that we'd be able to present each of you with a thumb drive before you left with all key materials. I think people had wonderful materials to share, and we'd really still like to disseminate it. So what we propose to do is, if any speakers have any material that they put on a thumb drive that they don't want disseminated, please let Sean or me or Andrea Karras know. Otherwise, in the next few days, we'll proceed, assuming that we can assimilate that and that we can share it. Hopefully, that will disseminate more information to many of your own local key stakeholders.
Can I just say one thing to that? Yes. So if you brought a thumb drive today and had me do it this afternoon, please email that to me, because we don't have that. The other ones we have.
We can harvest it, but probably it would be
because I didn't have time to save them. I just opened them. Like the 3 that I got this afternoon. So I'll follow up with those.
Okay, so we will get all the electronic information, put it together, and get out thumb drives. One of the other things I heard that I don't think I have a neat answer for today is that there already are a lot of resources out there that some of us are aware of, but not all of us. So there's wonderful work being done by AIDS Foundation Chicago, Project Inform, San Francisco AIDS Foundation. We have some work here. There are other materials that some of the demonstration projects nationally have put together. I won't volunteer us to be a clearinghouse, but I think we'll try to think about a process maybe where there can be ways that we can cross-reference each other more effectively, because it's just a shame to have all the, this wonderful material and the web, and not to be able to tell people here's a website, and then you can go through that website and easily access some of the other information. Lastly, we didn't have end result that would say the next meeting is going to be X or Y, and so we clearly don't have time today to have the conversation say, how do we disseminate this, or would it be useful to bring people together again, or a different subset or of people to focus on. But many of us are in constant conversation with each other. Some of us who've not met each other before now can be in conversation with the other. So let's keep up the conversations and try to think about how this is not a static process, because we're in a very dynamic era in terms of health reform, in terms of recognition of more comprehensive vision of health for sexual and gender minority populations, other populations that have been disenfranchised. And so I think we want to keep this conversation going and try to get it right, particularly as the ACA comes into to fruition. I would be remiss not to acknowledge the non-restricted educational grant that we had received from Gilead to support this meeting. We don't feel that anything today was trying to shill for anybody. The goal here is not to to get people needlessly on medication, but I think it is to make sure that key stakeholders have some idea about what we know about these modalities for prevention, and thinking about how we can do a better job to have a more comprehensive frame that really incorporates the new information into a broader vision of sexual health. I want to thank all my colleagues at Fenway, and thank you all for being here, and it's been really a great day. Thank you.